Hello everyone, myself Dinesh Dangar, and today we are going to discuss antitubercular drugs. These are the drugs which are used to treat tuberculosis. So first we will understand what is TB. TB is basically chronic granulomatous disease where we can see the formation of granules or a kind of granulomatous disease. It is caused by Mycobacterium tuberculosis, a kind of bacteria. Tubercles are formed in the infected organs, and it may happen that it may reside into specific organs only. If it is not treated, it may migrate to the other organs, leading to further infection. Tubercles. Formation of infected tissues of nodular formation, or a kind of nodules are formed with Mycobacterium tuberculosis bacteria, and further their growth can be seen to those nodules only. These bacilli are generally inhaled by a person. So these are the bacteria which may enter into the body through respiratory tract. They are inoculated into bronchioles and alveoli for further multiplication. Microorganisms are multiplied to the sufficient action. In many cases, it may not evoke suddenly, but it may take some time. Antigen antibody reaction is evoked by cell mediated lymphocytes, and further there will be a formation of tuberculi. Goals. What will be the goals of antitubercular drugs? First, that is to kill those dividing bacilli. If patient is non-contagious, transmission of TB is interrupted. Second goal, that is to kill persisting bacilli, that is to effect, cure and prevent the relapses of tuberculosis. Prevent emergence of resistance so that the bacilli remain susceptible to the drugs. So these are the major three goals while going with the antitubercular agents in cases of tuberculosis. Combination therapy. Due to slow growth rate of mycobacteria and their intracellular location, combination therapy will be opted. Here, in cases of TB, the disease that is chronic in nature and therapy may be continued for 1 to 2 years. In many cases, while with single drug administration, there might be a risk of development of drug resistant for a specific strains of mycobacteria, and these kinds of resistance are usually seen and their occurrence may be high. The drug toxicity due to the high doses of a single drug, and this can be overcome by the combination therapy where generally 2 to 3 medicines are given together and a regimen will be formed. While coming to the classification, drugs used in tuberculosis, it can be divided into two: first line drugs and second line drugs. First line drugs will have a high efficacy and low toxicity, whereas second line drugs may have a low efficacy with higher toxicity incidences. First line drugs are Isoniazid, rifampin, pyrazinamide, ethambutol, and streptomycin. Second line drugs are opted in the cases when there will be a development of resistance due to the first line drugs. Drugs that comes under second line drugs are ethionamide, paraamino salicylic acid, cycloserine, amikacin or capreomycin, fluoroquinolones and rifabutin. Next one, that is alternative grouping, and this classification is taken from the 8th edition of K.D. Tripathi. Here it is divided into 5 groups. Group 1, that is first line oral drugs, that is Isoniazid, rifampin, pyrazinamide, ethambutol. Group 2, it includes injectable drugs, that is streptomycin, kanamycin, amikacin and capreomycin. Group 3 includes fluoroquinolones, that is ofloxacin, levofloxacin, moxifloxacin and ciprofloxacin. Group 4 includes second line oral drugs, that is ethionamide, prothionamide, cycloserine, terazidone, paraamino acid, rifabutin and rifampicin. Group 5, that is unclear efficacy drugs, and it can be observed with bedaquiline, clarithromycin, clofazimine, linezolid, coamoxiclav and imimapine or cilastatin. Now coming to the mechanism of action of first line drugs. Here in cases of antitubercular drugs, the major effect can be observed with mycolic acid, which is the chief constituent of bacterial cell wall. Other than mycolic acid, it includes arabinogalactan, peptidoglycan, and other sites will be mitochondria, that is ATP. Next is DNA synthesis as well as ribosomes. Major drug, that is Isoniazid or prodrug. It acts on the synthesis of mycolic acid. It inhibits the synthesis of mycolic acid. Second, that is pyrazinamide. It acts on cell membrane as well as on mitochondria and it interferes with the ATP synthesis. Third side will be DNA, where rifampin acts on the RNA polymerase and it interferes with the RNA polymerase, leading to dislocation of the RNA polymerase, leading to further failure of generation of new DNA molecules with the help of mRNA. Fourth site, that is arabinogalactan and the peptidoglycan synthesis, and it will be inhibited by ethambutol. Streptomycin. Streptomycin inhibits the protein synthesis which is carried out on ribosomes in bacterial cell, and the specific bacteria will be Mycobacterium tuberculosis. The prototype drug and the first choice of drug, that is Isoniazid. It is Isonicotinic acid hydrazine or Isonicotinyl hydrazide. It is most active antitubercular drug. Along with rifampicin, pyrazinamide and ethambutol, it will be given in combination therapy. It is bactericidal for rapid growers and bacteriostatic for slow growers. It is effective against both intra and extracellular bacilli. Here, tubercular bacilli, they are resistant to antitubercular therapy and it can be overcome with the help of combination therapy. Activity is on growing bacilli and not on resting forms. Here the major drawback, that is while many bacteria may have a slow progression, that is slowly dividing, in that cases combination therapy may have a certain disadvantages, but in most cases it can be overcome. While coming to the mechanism of action for Isoniazid, it inhibits the mycolic acid synthesis which is the major or chief constituent of bacterial cell wall. It is high molecular weight branched beta hydroxy fatty acid and it is important components of the cell wall of mycobacteria. bioactivation of isoniazid. Generally, isoniazid will be get activated with the help of mycobacterial catalase peroxidase enzyme. After that, it will be converted into their active metabolites, which interacts with the inherent A gene. And again, drawback is that in many cases, isoniazid may show resistance due to the inactivation of mycobacterial catalase peroxidase enzyme by mycobacteria itself, leading to the failure of therapy. Resistant strains is associated with the loss of this enzymatic activity. While coming to the pharmacokinetic parameters, they are absorbed orally and metabolized in liver. Adverse effects: it produces peripheral neuritis, gastrointestinal disturbances like loss of appetite and constipation. It may produce hepatotoxicity, and generally co-administration of pyridoxine reduces the peripheral neuritis. Second drug, that is ethionamide. It is 2-ethylthioisonicotinamide. It is secondary drug. For isoniazid resistant tuberculosis and patients resistant to isoniazid will be preferred with the ethionamide. Gastrointestinal intolerance can be seen as a side effect, and even it may produce visual disturbances and hepatotoxicity. Third, that is Paraamino salicylic acid. It is basically 4-amino salicylic acid. It has got sour taste, may lead to the gastrointestinal tract irritation. Generally, it is given in forms of their salts, that is sodium, potassium, or calcium salts. In the salt form, more water soluble, and it may produce less gastrointestinal tract irritation. Generally, aluminum hydroxide gel is included in its formulation to reduce GI tract irritation that is caused by the drug. While coming to the mechanism of action, it is just similar to that of sulfonamides, that is, it inhibits the dihydrofolate synthetase, so there won't be a further formation of folic acid, which is again used for the synthesis of dihydrofolic acid, and so at last there will not be a formation of protein synthesis. Uses: many years it was considered as first line of drug, generally included in combination regimens with streptomycin and isoniazid. Now the combination of paraamino salicylic acid, that is PAS, plus ethambutol and rifampicin is used. Next is rifamycins. These are the group of chemical related antibiotics and obtained by the fermentation from the cultures of the Streptomyces mediterraneae. They are also called as the ensamycins. They are grouped in rifamycin A, B, C and D. Rifampicin is a first semi-synthetic derivative obtained from the Streptomyces mediterraneae, and it is bactericidal in nature, whereas rifabutin is a secondary or second semi-synthetic derivative obtained from the Streptomyces mediterraneae, and again it is bactericidal in nature. Rifampicin mechanism of action: it binds to the beta-subunit of DNA-dependent RNA polymerase, and it further inhibits the formation of bacterial RNA. Food reduces its oral absorption, so generally it will be given on empty stomach. It may cause reddish-orange discoloration of the urine, saliva, tears and the skin. Adverse effects: it interferes with the liver function in some patients and should not combine with other potentially hepatotoxic drugs or in patients with impaired hepatic function, and it can be observed with chronic alcoholism. Hepatotoxicity is high when used with Isoniazid, because even Isoniazid may produce hepatotoxicity. powerful inducer of hepatic cytochrome P450 oxygenase. So it can markedly potentiate the actions of drugs that are inactivated by these enzymes. Fifth drug, that is cycloserine. It is basically 4-amino 3-isoxazolidine drone. It is an analog of D-alanine. It is rarely used because of its relatively weak potency and frequent toxic reaction. So it comes under second line of drugs. It is only used for patients who fail to respond other tuberculostatic agents only. It is administered along with other drugs, commonly Isoniazid. While coming to the mechanism of action, it prevents the completion of major building blocks of the peptidoglycan, and this peptidoglycan will be present in bacterial cell wall. Here in this case, mycobacteria, the major or the chief constituent, that is mycolic acid. Other than this, there will be a presence of peptidoglycan too. It prevents the synthesis of cross-linking peptides in the formation of bacterial cell wall. Okay, so this is all about antitubercular agents. Thank you.